Welcome to the FMP Essentials Show. I am Dr. Yousef Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials Show.
Disclaimer: the information presented in this podcast is for educational and entertainment purposes only. It does not constitute medical advice and should not be used to diagnose, treat, cure, or prevent any disease or health condition. Any statements or claims made about specific supplements, nutrients, or other products have not been evaluated by the Food and Drug Administration. Supplements are not intended to diagnose, treat, cure, or prevent any disease. The views and opinions expressed by guests on this podcast are their own and do not necessarily reflect the views of the host or producers. We are not responsible for and do not endorse any statements made by guests. Listening to this podcast does not create a doctor-patient relationship and does not give listeners the right to practice medicine or provide medical advice to others. Only licensed medical professionals can legally practice medicine or provide medical advice. Always consult with a qualified healthcare professional before starting any new diet, exercise program, or supplement regimen, especially if you have a pre-existing medical condition or are taking medications. By listening to this podcast, you agree that you understand and accept this disclaimer. Now get ready to dive in and enjoy the show.
Hello, everybody. Welcome to the FMP Essentials Show. I am extremely excited to have not only one of the best functional medicine physicians on the planet, but also one of my mentors who I have learned so much from over the years. He actually has a decent sense of humor as well. I may have him beat there. I don't know. We'll find out by the end of this. That being said, Dr. Sult, welcome to the show. Can you give us your 76-second bio?
Well, I don't think it'll take 76 seconds. So, I have dyslexia. So that means I can't spell my own name on most days, which also means I wasn't maybe the best college student there ever was. So I didn't get into med school, and I went to acupuncture school and started hearing about these foreign medical schools. And I thought, well, holy mackerel, I can't even speak English. How am I ever going to manage Spanish? Because everybody was talking about Guadalajara. And then I learned about some schools in Grenada, went to Grenada, spent 2 years there, then took a bunch of tests and transferred to UCLA, graduated from UCLA. While I was at UCLA, I met Norman Cousins. Norman Cousins, author. He was writer and an editor, and wrote a book about his own ankylosing spondylitis and how he cured it with laughter, watching Laurel and Hardy and things like that, speaking of laughter. Anyway, he became a really important mentor to me, and it was sort of the scientific embodiment of what I had learned in acupuncture school, but also what I had learned in Grenada, living with a Grenadian family for a year, and them being very interested in preserving indigenous culture and bush doctors. And I thought bush doctor was like Australia and the outback, right? But no, bush means herbal medicine. So it was this really interesting sort of scientific embodiment. I became kind of a disciple of Norman Cousins, and did all of his copying. In med school, nobody has a budget, right? So you got to sneak into the surgical department and use their copying machine. And then when you get caught there, you got to go over to psychiatry and use their copying machine and whatever. So I became very good at being sneaky like that. And then I was in practice. One of my very first patients in private practice was a woman with chronic fatigue syndrome. And she said, I'm seeing this nutritionally oriented doctor. I was in South Lake Tahoe, California, and she was seeing this nutritionally oriented doctor down in Sacramento. And I said, well, okay, first of all, what is a nutritionally oriented doctor? What are you talking about? And then it kind of like, oh yeah, acupuncture and herbs and Norman Cousins. And it kind of like all of it kind of went woof back together. And that he replugged me into Jonathan Wright and Alan Gaby and Jeff Bland. And I started going to all of the webinars and getting the little cassette tapes back in the old days, metabolic update. And then it changed to preventative medicine update, and then functional medicine update. And so that's sort of my journey. And somewhere along the way, I got asked to give a lecture that I found out I was taking over Jeff Bland's lecture at AFMCP, and I thought, oh boy, that's some big shoes to fill. What am I going to do here? And then from there, I just, one thing led to another, and I became a fairly regular contributor to IFM.
Nice. And for those of you that don't know, Dr. Jeff Bland is one of the founders of functional medicine. I believe him and his wife coined the term functional medicine, and IFM, the Institute for Functional Medicine. Dr. Sult and I are both teachers for the Institute for Functional Medicine. So that's impressive. So that goes from dyslexia, thinking that you don't know, or that there's no way I can be a doctor, to not only being a doctor, kind of being a super functional medicine doctor and teaching other practitioners about functional medicine. That's very impressive. I can't wait to get into our topic today. So we here at FMP Essentials, we look at the functional medicine practitioner as a tree. We use the tree analogy, and the trunk of the tree is a big part of the structure. And to the practitioner, to us, that's core knowledge. So we're in the core knowledge section. And today, Dr. Sult, you asked, or you wanted to speak about Lyme disease. Tell me, why did you choose Lyme disease? We could have talked about anything. Why is it important?
Well, let me just say that I didn't choose Lyme disease. Lyme disease chose me. I was, as the saying goes, fat, dumb, and happy, and living in South Lake Tahoe, California, where there's almost no Lyme disease, although I saw my first case of Lyme disease there. But then one day my wife announced that we were moving, and I thought it was a conversation, but we were actually moving to her hometown in New London, Minnesota. Well, 2/3 of the ticks in northern Minnesota carry Lyme disease, and all of a sudden, being the new doctor in town, what happens? Everybody with chronic pain, everybody with chronic this, everybody with chronic that comes to you because everybody else has, already dismissed them or something. And I started seeing all of these people with these weird symptoms, and I started, trying to figure it out. And the conventional wisdom wasn't getting there, so I had to dig into what's next, what's going on. So there's this gigantic population of people. It's actually about 10% of people who get Lyme disease go on to have some sort of long form of Lyme, right? It's often called post-treatment Lyme syndrome or some other thing. And just trying to tease that apart from a functional medicine point of view became an interesting puzzle. I like to think of myself as the medical Sherlock Holmes,
Yeah.
My nurse practitioner once said I was just like Dr. House, except for he had a better bedside manner.
Oh, that wasn't a compliment, was it? So, Dr. Sult, how many people do you think have Lyme disease and don't even know it?
Oh boy, a whole bunch. I mean, it depends a little bit. So Lyme disease is in every state. It's been reported in every state, and it's underestimated. According to the CDC, it's underestimated by about 13 times. So it's estimated that there are, 400,000 cases in the United States every year, which means that 1/13 of those are actually diagnosed. And so, whatever that math works out to, 300,000, 250,000, whatever it is, don't even know they have it or had it. And about 10% of those, 10% of the 400,000 go on to get long symptoms. So it's a lot of people who don't even know they have it.
And it's interesting. Maybe we can go down at some point, we can talk about people that think they have it and might not have it. Because
absolutely. You can treat the wrong thing until the cows come home and you don't get better, right? So that's a huge piece of this murky area of controversial medicine called chronic Lyme.
So let's talk about diagnosing. First of all, Lyme is caused by what causes Lyme?
Almost exclusively, there are caveats, but almost exclusively, it is a bite from a black-legged tick, an Ixodes tick. And the most common cause of Lyme is the bug Borrelia burgdorferi, but it has a number of Borrelia cousins that can also cause Lyme-like symptoms and or tick-borne relapsing fever-like symptoms. And then there are also co-infections, they're typically called, which are Bartonella and Babesia and Ehrlichia and Anaplasma and things like that. And then there are imitators like Powassan virus or tick-borne encephalitis virus, or, all kinds of different things that can imitate Lyme. So it's, talking about Lyme disease is sort of, I would say that's more of the layperson's word. And what I would say is more, we're talking about tick-borne illness or vector-borne illness more generally.
It's interesting that you said every state has Lyme disease, because like we're here in Florida, and in Florida we're told, hey, yeah, there's no Lyme disease here. You don't even have to think about it.
20,000 cases in Florida were reported to the CDC in, I think, about 10 years ago. I think that's the most recent math. Yeah, and if 20,000 cases were reported, no, wait a minute, I might be wrong there. That might be the 13 times. But anyway, it's there. And I actually had a patient from Florida, and he went in and he had a bullseye rash in the whole 9 yards. And the doctor said, well, listen, we don't have Lyme in Florida. And he said, yeah, but I have a cabin in northern Minnesota where 2/3 of the ticks carry Lyme. And he said, yeah, but we don't have it in Florida. And so my response was, why don't you get a copy of Trains, Planes, and Automobiles and give it to that doctor so he can understand how people travel?
Would get that. Well, long story short, he did have Lyme, huh?
He did have Lyme, and we treated him successfully. He had it for about a decade.
Okay, so I hear people call it Lyme, and I hear people call it limes.
Yeah, right. So it's named after a town in Connecticut called Lyme, Connecticut. And I suppose you could make it plural possessive if you wanted to, but it's Lyme disease after the town.
So saying Lyme's disease is saying it wrong, or we're not going to judge. We're very neutral with.
Well, I don't really care what you call it personally, but I mean, like, so if it was Dr. Elyaman's syndrome, then it would be Dr. Elyaman's syndrome, plural possessive, but it's named after a town, so and it's not exclusive to that town. So,
okay.
Yeah.
So what symptoms would make somebody think they have Lyme? Limes. What symptom would make people think they have limes?
More than one case of Lyme at the same time. So first of all, let's sort of distinguish between acute and chronic, right? So acute Lyme, which everybody agrees exists. There's no controversy about acute Lyme. Acute Lyme, when I got acute Lyme, I got up one morning. I actually felt perfectly fine the day before, but I woke up one morning and I'm sitting at the side of the bed and I noticed that I'm stiff and sore and there's sweat just dripping off the end of my nose. And I thought, wow, something's strange here. And I remembered pulling a deer tick off of me from being out at the local park probably 2 weeks earlier. I never had an erythema migrans rash. I never had any of that stuff, but I thought, oh, Lyme disease. Now, here's another interesting caveat. A bullseye rash or certain symptoms can show up in 3 days to couple 3 weeks maybe, but the Lyme test may not be positive for 3 to 6 weeks. So like in my case, I might have gone into, my primary care doctor or just drawn the test myself, and likely I would have had a negative Lyme test. And for many people, that's exactly what happens. They actually even go in with an erythema migrans rash, which all by itself with a good story is diagnostic, even according to the, IDSA, the Infectious Disease Society of America. And yet the doctor, not knowing that, will say, oh, well, let's just confirm this. Let's get a test. The test will be done too early. It'll be negative, and that takes Lyme off the table. And so then they get treated for who knows what and go on to get disseminated chronic infection.
And the rash, you said, I think you mentioned it earlier, what percentage of people, you said it's a bullseye looking rash.
It's a
Weird.
bullseye-looking rash. It's called an erythema migrans, but a significant fraction of them don't look like a bullseye. A significant fraction of them are in your hair, on your back, someplace where you can't see them. Often when they're seen, they're misdiagnosed as a cellulitis or a ringworm or something like that. And now the CDC and the Infectious Disease Society of America feel that 70 to 80% of people with acute Lyme have a rash. But there's lots of studies that suggest that number might be closer to 50%. So even if if you have the rash, well, it's only 50% of people have it. And there's a significant percentage that's going to be misdiagnosed. So, the rash isn't as helpful as we wish it would be. And then early detection with the two-tiered test is maybe, sensitivity of 50%, which is pretty terrible.
And you said after 6 weeks.
If you after 6 weeks is when the test is going to become positive.
Right. After 6 weeks. So by then, it's kind of been, Lyme has been cooking for a while.
Lyme has been cooking for a while, yeah.
All right. So you mentioned sweats. So you woke up with sweats.
Oh, yeah. So migrating joint pain, sweats, low-grade fevers usually, migrating joint pains, and fatigue.
What do you mean by low-grade fever?
Say that again?
Low-grade fever, like meaning 100.4 or 3?
No, below 101.
Below 101.
Really. But, the problem with all of these diseases is they don't read the book.
Yeah.
So they can do pretty much anything they want, right? Some people spike a big fever because they have a more robust immune response. Most people have more of a low-grade fever where they just are, below 101.
So you said migratory joint pain. Which means you'll have joint pain in one area and then you can have joint pain in another area. How migratory is it if they read the book?
If they read the book, they will tell you that their knee hurts so badly that they can't walk. And then 2 days later, their knee is absolutely fine. And a couple of days after that, their left shoulder is so stiff, they can't even use their arm.
Do they have swelling or redness or?
So there's two issues here. One is Lyme arthritis, where they clearly have all of those things. But most people don't have Lyme arthritis. Most people have a very sort of non-inflammatory joint pain, or at least in my view, it's it's probably neurological neurological joint and muscle pain that migrates with really little symptom or little sign actually at the actual painful site. And very frequently people will complain of very severe muscle pain. And, like my calf or my ham hurts so bad, and you just grab it and squeeze it as hard as you want, and it doesn't make it worse. So it's obviously not a local traumatic thing, right? So it's a very weird kind of pain. Now, they can have that, but that's not the common thing.
Right. Commonly, you're saying it's probably in the nerve, so they're feeling it, but you can't elicit it by pushing at it. So,
right.
So sweats, joint pain. Did you have joint pain?
I didn't, because I started doxycycline the day I started sweating.
Yeah, you had an unfair.
Yeah, exactly.
Okay, so what else can they have? Rash, sweats. They can have migratory joint pain. What else?
Migratory joint pain, migratory muscle pains, and brain fog. So this sort of, think of it like it's very similar to the flu, right? The real flu, not the stomach flu that everybody calls the flu, but the real flu. It's very similar to that in many, many ways. Acute Lyme.
Okay, so the acute Lyme, they have these symptoms, and usually you're going to want to treat them. What would you treat them with?
From a conventional point of view or from a functional medicine point of view?
Let's go conventional first.
Yeah.
And for acute now.
Yeah, for acute. So it'd probably be the same. I see almost no acute Lyme, because by the time they get to me, they've been sick a long time. But the standard of care for Lyme disease is up to 4 weeks of doxycycline.
Okay. What determines whether it's 2 weeks or 4 weeks or?
I would say preference of the practitioner. The IDSA will tell you, 10 days to 14 days is probably more than adequate, but they concede that some people might need 4 weeks.
Okay.
So if you live in an endemic area and you see all these people who are chronically suffering, most of the docs around here are going to give 4 weeks.
Okay. So that's acute Lyme. Doxycycline, what if they're allergic to doxycycline or they have issues with it?
Yeah, so you can use, something like Biaxin or Zithromax, or you can use like amoxicillin. The problem is Lyme disease is very good at shedding its cell wall and becoming a cell wall deficient form, also called an L form or a spheroplast. And of course, the penicillins, they work on the cell wall. So the moment you expose them to a cell wall active antimicrobial, they'll just take off the coat and become resistant to it.
So going back to acute Lyme, the conventional way of diagnosing it is what? Because obviously you can't really catch it, because by the time the blood work, because by the time the blood work is positive, they've already had it for 4 to 6 weeks, right?
Right. So both the IDSA and the CDC will tell you that in the face of an erythema migrans rash and a good history, that's all you need to diagnose Lyme. If you have extracutaneous manifestations of Lyme, in other words, roving joint pains, roving muscle pains, fatigue, brain fog, then history alone is not enough. And they want you to do a 2-tiered Lyme test. So that's going to start with either an IFA or an ELISA. And if that is positive, that you will go on to a Western blot, or there's a new updated idea where you can do 2 separate ELISAs, a screening ELISA and then a different ELISA. And they really, you have to have a good history, right? So you have to be either live in, work in, travel in, vacation in a Lyme endemic area. Well, it's in every state. So what does that even mean, right? There are hot spots of Lyme, Lyme, Connecticut, kind of probably a hot spot, but all of the northeastern seaboard and then across to the Great Lakes is really the hotbeds of Lyme. But then, like in Texas, they have the Lone Star tick, which carries some bugs too. So it's a little more complicated than the IDSA might have us believe, in my opinion, and many others. But anyway, so what happens there? Well, the IDSA will tell you that this test has a specificity of like 99%, which it does. But the sensitivity is arguable. And they will say, oh, no, the sensitivity is very high. But other studies, suggest that the sensitivity of that 2-tiered test may be as low as 40, 50%.
So that means that we could 50 to 60% of people it would miss. Right.
Exactly.
And you said if they have extracutaneous manifestations, that's when they really want you to have the blood work showing it.
Right. And in fact, in some communities not so long ago, doctors were having their license taken away for giving people antibiotics with a negative Lyme test.
Wow. Yeah. And really, you want to treat them early. You want to treat before the test could actually possibly be positive.
When you and I were in med school, before, maybe not you, but me, before.
You were way before me.
I know, centuries before you. We didn't really have good ultrasound. We certainly didn't have good CT scans readily available. And so somebody comes in with right lower quadrant pain, and you do the exam and you go, ooh, there's peritoneal signs here. You consult the surgeon. He's going to take you to the operating room, and we're going to expect 30% of those appendices to be normal, because the consequence of missing an acute appendicitis back then was potentially fatal, right? I mean, now, we got gorillacillin and nucamycin that we can give people if they've got peritonitis. But back then, peritonitis was a surgical disease, right? So I think of Lyme disease in the same way. Personally, I don't think that we have the luxury of not treating somebody who we have reasonably ruled out, I consider Lyme disease a diagnosis of exclusion. We've reasonably ruled out the big players that this cluster of symptoms could be, and they live, work, play, whatever in a Lyme endemic area. We don't want it to, become a tertiary infection, or what we'll hopefully get into much more later, become a post-acute sequelae of Lyme disease, right?
Which now, I guess, so that brings up the question: how long do you have to treat somebody before they convert over to a more post-acute or a chronic Lyme?
Well, that's an area of chronic, not just debate, but hot argument, frank exchange of views, as I like to say when I'm speaking with my wife. We don't have arguments; we have frank exchange of views.
I think I'm going to use that. That's
Anyway. So, can I tell a really awful joke?
Sure.
So in the 30s and 40s, and even before that, there were these thick books written about syphilis, right? And syphilis could do anything, right? I mean, syphilis is a spirochete also. It's a distant cousin to Lyme. So we have these thick books, and it can cause this weird mental illness, and it can cause joint problems and heart problems and all kinds of things. The bad humor here is the major difference between syphilis and Lyme disease is it's more fun to get syphilis, right? So, I mean, a tick bite versus the way you get syphilis, there's a difference, but it's still a spirochete, and they're still able to travel, and they're still able to get across the blood-brain barrier, and they're able to go everywhere and do everything. So, how long does it take to go from primary syphilis to secondary syphilis to tertiary syphilis? Well, it's variable, and it can take anywhere from, in an immunocompromised person, days to weeks, to somebody who's very robust with it. They will fight it off on their own with a robust delayed hypersensitivity response and be free of disease with no treatment whatsoever. And it's the same for Lyme.
What would conventional medicine say? How long before you call it chronic or post-acute? Or
3 months.
3 months. Okay. All right. So they're like, yeah, within 6-7 weeks, you should be treating people, and give them 2 weeks, maybe a month of antibiotics, and hopefully they'll be okay.
And if they're not okay, the IDSA says it's not infection, which I'm partially agree with that statement. It's not infection, and or it may be an immune dysregulation. They really haven't embraced the whole idea of post-acute sequelae. If there is a silver lining to the pandemic, it's this broader understanding of a post-acute sequelae, which is a concept we've known about for decades, but it really hasn't been in the sort of forefront consciousness of practitioners until really now. But I think that's a really big piece of the puzzle we need to be thinking about, that I think most organizations, even alternative Lyme organizations, aren't really embracing right now.
So by the time people come to you, they've probably been treated with antibiotics, the first line antibiotics, and they're continuously having symptoms. They continue to have symptoms. So they show up at your doorstep. And is it a virtual doorstep now?
Well, either one.
They can show up at your physical or virtual doorstep.
Yeah.
So tell me, how do you deal with that? What would make you think, let's say they don't even remember a tick bite. You could, of course, if they have a tick bite and they have all the classic, they don't even have a tick bite. What is going to make you think that this person has, what do you call it? Post-acute, or you call it chronic Lyme or chronic Lyme?
Post-acute sequelae of Lyme. I coined that term. I'm the only one in the universe that uses that term. So,
all right. So do you have a trademark on it yet? If not,
yeah, no, I probably should, huh?
You need to make, no, you don't do anything. I'm going to make a phone call. Right.
Yeah.
What does the rest of the world call it?
Chronic Lyme disease.
Chronic. Why do you like post-acute versus chronic?
So there are a whole bunch of well worked out mechanisms, right? I'm scrolling on my other screen here to just, so I don't screw up too badly. There's a whole bunch of pretty well worked out mechanisms surrounding post-acute sequelae of SARS-CoV-2, right? The fancy name for long COVID. So, certainly long Lyme or post-acute sequelae of Lyme could be chronic infection. And there are a bunch of mechanisms that can allow that, right? There's immune evasion, there's altered surface proteins, there's blah, 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 right? There's antigen variants, there's formation of biofilms, then there's mechanisms for immune dysregulations. There's the bug, well, first of all, the tick can cause immune suppression from its saliva, but then the bug itself, Borrelia, can. And then it alters Th1, Th2 balance. It can cause chronic immune inflammation, activation. It can cause T cell exhaustion, just like COVID does. Auto-inflammatory conditions can develop. Inflammasome activation. Nobody had ever heard of an inflammasome before COVID, but they've been around since we evolved, right? So inflammasome activation, neutrophil and macrophage dysfunction.
Can you explain?
And then,
what does inflammasome mean?
well, so inflammasome is an overreaction of inflammatory byproducts, right? So excess production of IL-1 or IL-8 or, name the inflammatory thing, right? So,
So you're kind of overly getting inflamed. Your body's overreacting.
yeah, it's like the brakes come off of the inflammation train. So it's a runaway train of inflammation.
So you get somebody in with what others may call chronic Lyme, which you and I now, since I'm getting the trademark on it, may call post-acute Lyme. They come in. Tell me, what is your workup? What blood tests are you going to do on them?
Okay, so that goes back to that 10%, right? If you're coming to me, you're part of the unlucky 10%. You're part of the 10% of people who didn't either just clear it on their own or go to the doctor and probably for no good evidence-based medicine because you were just ill, they gave you antibiotics, or you actually had a Lyme test that was positive and you got antibiotics, right? You're not in that group who were cured. You're part of the group that either didn't get treated or didn't respond to treatment appropriately, and now you have chronic Lyme. And my first question is really a functional medicine question. What over why? So why over what? What is the diagnosis? So, they're going to come in, we're going to work them up one way or another and have a high index of suspicion for Lyme disease through, eliminating rheumatoid arthritis and this, that, and the other thing, right? Just doing the exclusion.
Right.
And
so
then,
hold on. So let's start with that. So we're going to rule out autoimmune conditions. So you would check
simultaneously. So let's
Right.
say they come in and I have a really high index of suspicion that this is Lyme disease. So I just do a fancy Lyme test. So there's several companies that do this. iLads.
Let's go back a little. Let's go back. Ruling out the autoimmune rheumatologic conditions. What does that panel look like? You're going to check rheumatoid factor, you mentioned. I'm
going to do an ANA cascade. I'm going to do
ANA, looking at like lupus and other autoimmune conditions.
Yeah.
Okay. What else are you going to look at?
An RA, SED rate, C-reactive protein.
Okay. Anti-CCP antibody.
Yeah, that's
okay. SED rate, CRP for inflammation, anti-CCP antibody. Is there anything else that you're looking at from a rheumatologic rule-out point of view?
Well, an ANA cascade. So the ANA comes back positive, then they're going to do a whole big battery of tests to kind of try to look at maybe the subtypes of positivity of ANA.
Okay.
That's the main workup, right? I'm not going to go too far out into the weeds.
And with regular, let's say they haven't done, with regular blood work, with like Quest and LabCorp and that type of thing, you would check maybe a Lyme titer. What would you look at?
So let's start at the beginning. I'm going to do a CBC, a CMP. I'm going to do that ANA cascade, an RA, a CCP, a CRP, a sed rate, all the usual suspects.
Okay.
They probably already had a conventional Lyme test, and it's probably negative.
Would you recheck it? Let's say
Probably
it's
not.
okay.
I mean, I might, if they had it very, very acutely, I might recheck it.
Okay.
But the standard kit, as it's called, for Lyme disease is made out of Borrelia burgdorferi sensae stricto. In other words, subspecies B31.
Mm-hmm.
And we now know that there are about 40 some odd species of Borrelia that can cause Lyme-like disease and or tick-borne relapsing fever.
Hold on. So you said 46 types?
40 something.
So you're telling me that the test that we look for is looking at one out of the 40 something possible types of Lyme disease.
That's what I'm telling you. Well,
so you're telling me that probably if you check for Lyme, there's probably 40 other types of Lyme of Lyme that will not even be in the test.
yeah, and it gets worse because of the Limerix vaccine. The two most potent antigens aren't even in the standard kit for Lyme disease.
Wow.
So now there's a lot of cross-reactivity, right? So I don't want to say that if you had Borrelia abzilii, it absolutely wouldn't show up on the standard kit, but it's less likely.
So it could still pop up. It could still show if it's one of the other 40 some types of Lyme. It could still show up, but it's not going to be as likely to show up.
Correct.
Okay. Yeah.
Well, in the United States, overwhelmingly, the most common cause of Lyme disease is Borrelia burgdorferi.
Okay. So you're still, it is looking at the most common cause, but there are other little possible causes of Lyme that it wouldn't pick up. Okay. So because of that, because the standard lab is only looking at one form, what do you do?
Well, getting back to that unlucky 10%.
Yeah.
What's unique and different about this individual, right? So just like long COVID, what do we know about those people? They have metabolic syndrome. They have this, they have that, they have the other thing, right? Oh, it's the same thing for chronic Lyme.
Okay. So you do kind of a functional medicine panel to see what the other underlying imbalances that may cause disease are.
Yep.
To see if they have maybe insulin resistance. So what are you looking at? Insulin resistance. You can do like an insulin resistance score, right?
Sure. A HOMO-IR or something.
HOMO-IR. What other imbalance are you looking at?
Well, so I already mentioned I do a CBC and a CMP. So I'm looking at all that stuff for all the usual suspects. I'm looking at looking more deeply at the CBC. I'm looking at a neutrophil lymphocyte ratio for inflammatory kind of ideas.
Well, can you explain that more? Because the CBC is pretty common to get a CBC. So
sure.
Tell me about the ratio.
So you look at the ratio between absolute lymphocytes and absolute neutrophils, or other way around, really, neutrocyte lymphocyte ratio. Okay. Numbers above 3 are inflammatory. Numbers below 3 are less inflammatory.
So it's mainly looking for non-specific inflammation, or is it looking more for bacterial infection? Or?
Well, it's actually fairly non-specific for inflammation.
Okay. And then, of course, platelets. What could platelets be looking like?
Yeah. Platelets are rarely that abnormal, but, you keep them low or high. I mean, platelets are an acute phase reactant, just like ferritin is.
Okay.
And then, of course, we're looking at the CRP. I'm doing more functional medicine testing. I really use a lot of Vibrant laboratories. So I'm going to do probably a total toxic burden with organic acids. The organic acid test is going to tell me something about nutritional efficiency rather than deficiency. So, and then it's going to tell me something about their mitochondria. It's going to tell me something about their microbiome, and a few other things, right? And then,
so you're looking at a stool test? Are you looking at a stool test as well?
No, this is all urine so far. And then the total toxic burden is going to look for mycotoxins, heavy metals, and industrial pollutants, because many people who are susceptible to the idea of chronic Lyme they don't detoxify well, and that has dimmed down their robustness of their ability to defend themselves, right?
Is it because they have so many toxins kind of floating around, it weakens their immune system?
Well, that's my theory. Yeah.
Okay.
So we live in a toxic world, right? Babies today are born with something just shy of 300 identifiable environmental toxins, industrial toxins. It's just right. But nobody cares. It's like everybody should be jumping up and down. And instead we go, well, thank God the plastic is BPA free now. Yeah, well, nothing else except for this bottle is BPA free. The wrapper that your food comes in has BPA in it. The athletic equipment you touch all day long has BPA in it. It's like it's
Cans, right? Can lining.
can liners. Yeah, a can liner. And what do? They put the food in the can, they seal the can, then they put it in a pressure cooker and then cook it in the phthalates that are in the can liner.
Yeah, but sometimes it's organic.
There's actually studies that show that canned organic food, conventionally canned, has phthalates in it because of the process in the can liner.
Crazy. So people read that organic label thinking they're good, but they don't recognize that the packaging. So you're digging and you're seeing what other imbalances are out there that could
I'm using the functional medicine matrix, right? So I'm looking for, immune and, digestion, or, what we call assimilation. And I'm looking for inflammation. I'm looking for, the whole thing, the psychosocial, spiritual components. A lot of people are, as you know, we live in the most stressed society outside of active conflict zones. And being in chronic stress, living paycheck to paycheck, all the things that is common and normal, we've normalized in America,
right?
That causes you to be in chronic fight or flight. Well, when you're in chronic fight or flight, you're shunting blood away from your gut. Well, that means you're not digesting well, you're not absorbing well. 70% of your immune system is the GALT, the gut-associated lymphoid tissue. Your liver is in that circulation, so how well are you detoxifying? Your adrenals are in that circulation, so how well are you mounting a stress response? So, it's a lot, right? There's a lot going on with these people, and it's not a matter of kill the bug. It's a matter of optimize the terrain the bug is living in, i.e. our patient, and then also kill the bug.
So you are a fancy guy. I mean, you have a sense of humor. It's gotten better since last time I talked to you. But you're also a fancy guy, and fancy people do fancy things sometimes. Is there a fancy Lyme test? No, I'm sorry. Is there a fancy Lyme's test that you could potentially check?
Well, it should be called a Lyme's test because it tests for a lot of bugs. So Vibrant Laboratory, so there's a number of them. So Igenics Laboratory is a very good laboratory, and they have updated the Western blot, and they now call it a Lyme immunoblot. But it's still a gel technology. Vibrant actually has a colorimic chip technology where they take the actual OSP-A, outer surface protein A, they put it on a chip, and then they measure, is it there or not, right? So instead of looking at a fuzzy gel where it's these fuzzy lines and is the lighting good? Do I have my glasses on crooked? Instead they've taken the gel out of the Western blot. We have the same antigens, but a better technology for measuring them. And then there's companies like Galaxy that, are using very advanced digital PCR technology and nano trapping technology to harvest antigens for looking at more direct. So there's direct testing, that would be PCR and antigen trapping. And then there's indirect tests, which would be like Western blots and, things like that.
Well, what's your go-to if you have somebody that you believe has post-acute Lyme and now you're getting that test on, what test are you going to look at first?
For Lyme specific, right now, my go-to is a Vibrant tick-borne panel. And they have two versions, 1.0 and 2.0. 2.0 goes into a lot of the imitators, right? But you can add that on later. So I do a 1.0, costs $400. But it measures a large number of Borrelia species, not just Borrelia burgdorferi. There's Borrelia, Epsilia and blah, 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 all of them, a bunch of them. Californiensis, that's my favorite one. Because of remember the old TV show, Californicated?
No, listen, you're way older than me.
Oh yeah, that's right. You know. But anyway, and then it also looks at the common co-infections, but it doesn't really look a whole lot at the imitators. But if that's all negative, I may add on the imitator test. And don't forget, as I said earlier, this is a diagnosis of exclusion. So even if the test is negative, if I have a high index of suspicion and I have worked my tail off to really eliminate other reasons they might have this illness, they're at least going to get a trial. I call it a diagnostic trial of therapy.
Okay. So I think that's, and you mentioned that you can check for imitators as well, but you do 1.0. Is the 2.0 much more expensive than the 1.0?
Yeah, it's like $950.
Okay, so save them $500 and try to do that first one. Now, what are the chances? Do we know? What are the chances that test says that they have it, that it's positive, and it's really not positive?
Yeah, 10% or so. I mean, so there's the CDC criteria, right? And then there's alternative criteria. So there are studies that suggest that a C6 peptide that is IgM positive all by itself carries about a 90% sensitivity and specificity. So, and then if you add on from there, if they have, let's say they have outer surface protein A and outer surface protein B and, variable antigen region, whatever, it starts to, it accumulates. So, and like all tests, right? You can do a cholesterol test, have the patient get up off the table, walk around the table and redraw them. And those numbers will be 10% different, right?
Right. Yeah, no, we see it sometimes. The standard labs will accidentally run a test twice on the same blood sample and the numbers are off. No, we know that. So so you do this, you're a fancy guy, you do this fancy extra test. You have come to the conclusion, whether it's positive or not, that this person has what conventional medicine calls chronic Lyme. So,
well, conventional medicine doesn't call it chronic Lyme because they say chronic Lyme doesn't exist.
Oh, so there's no conventional neuro Lyme.
So, well, that's a different thing. So, according to the IDSA, there's no convincing evidence that symptoms that persist after adequate antibiotic therapy, which they define as up to 4 weeks, if the person still has symptoms, they don't believe that it's still infectious.
Okay, but what about what about the concept of neuro Lyme?
So neuro Lyme and cardiac Lyme and all those things, they believe are autoimmune or autoinflammatory processes post-infection.
Okay, how do they treat them?
Well, some people will say, well, maybe it's behind the blood-brain barrier and we'll give you another 4 weeks of something big, some IV big gun antibiotic. But many times they'll treat it with some kind of autoimmune protocol, on some kind of a MAB or something like that.
So it's just, they're saying, look, your Lyme's disease kind of triggered a autoimmune condition. So we're going to weaken your immune system so you don't feel all these symptoms. Is that pretty much it? What kind of antibiotic may they give?
Ceftriaxone.
And that's, I would take it IV, so an IV ceftriaxone. Yeah. And a lot of times I know they get a PICC line in. How long would they treat that for?
So there's some, again, conventionally, not very long, 4 weeks. They're not going to treat it like osteomyelitis for 6 months.
So why are they confused? Don't we have AI now that could just tell us the answer?
We have AI, which reads a whole bunch of stuff, but is a very poor discriminator of fact from fiction, right?
Yeah, I get that, unfortunately. All right. So the conventional approach may give an antibiotic. They may give people something to kind of weaken the immune system, but then you are a conventional medicine on legal steroids, right? Healthy legal steroids. You're a functional medicine practitioner. So you already mentioned that you're looking to see the underlying imbalances that may throw somebody's system off. How are you going to treat that person with Lyme differently now? What is the extra thing that you're going to do, maybe within that lifestyle modification realm, the body supporting realm? What would you do?
Well, we're going to start by trying to convince them to go on a plant-forward ketogenic diet. So not vegan, not vegetarian, but just more, 3/4 of the plate should be low-carb veggies and a quarter should be what I call healthy protein. So that's all the buzzwords: organic, free range, wild caught, grass-fed, blah, 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 right? All that stuff. So that's the diet, a plant-forward ketogenic diet. Why? Well, it's really hard to grow Lyme in the laboratory. And it turns out you grow Lyme in the laboratory by giving them a whole bunch of sugar. So let's take the sugar away, make them weak, right? And then a ketogenic diet helps with neuroprotection. It helps with mitochondrial resuscitation. It helps with detoxification of fat-soluble toxins because it's a high-fat diet. So, I explain it to my patients by saying, listen, if you had a water-soluble toxin, we'd have you drink a bunch of water, flush it out. But these are fat-soluble, so we're going to give you healthy fats. And that's what a plant-forward ketogenic diet is.
So what is fat soluble? You're saying that the disease in itself is fat soluble?
No, I'm saying that I've done this total toxic burden, and we've probably found a number of toxins that are above the 95th percentile and a number of toxins that are above the 75th percentile. And we're going after those to optimize their physiology.
Okay, so they have toxins. We know toxins bind to fat. You want to get some fat in them to kind of mobilize things.
Correct.
Okay, all right. So you put them on ketogenic. Now we're functional medicine, and sometimes we do these advanced lipid testing. Actually, I do it all the time. And many times when they go on a ketogenic diet, their small density LDL shoots up, and their ApoB shoots up. And we see all of these things kind of thrown off with their lipid panel. Oh, the greens turn to reds or the yellows turn to reds. How do you handle that?
Well, so those people are going on more likely than not, they're going on an Atkins style, all double bacon cheeseburgers all the time instead of a plant-forward ketogenic diet.
Would you allow their levels to go off temporarily as they're getting better?
Yes.
Okay.
Yes.
Because I see that, especially.
There was just recently a study. I haven't fully read the study yet, but I just want to point out that there was a study done very recently that showed in the context of a ketogenic diet, these elevations did not, according to some testing they did, and I think it might have been calcium scoring or something, I can't remember. But these elevations did not translate to atherosclerosis. So I think there's more to the story of lipids than I think, the lipid markers in the face of the inflammatory carbohydrates, I think is a much more concerning issue, especially oxidized LDL. And you and I have talked about this before, and you complained about the hour-long video I had you watch and so on. But I think there's bigger and bigger holes are being poked in the lipid hypothesis.
All right. There's definitely more to the story than just lipids being elevated.
Yeah.
And to me, if you have by the time they've come and seen you, they are suffering. Their
Yes.
quality of life is low.
Their life has been robbed.
Right. And they need to feel better. And the body can function when ketosis happens. Anybody that's went on some sort of a ketogenic diet knows their mind is clearer. Their sleep has, they don't require as much sleep. They're more alert. It's like the body is designed to, when it goes in ketosis, it's ready to hunt because that's when our ancestors did it. And it's optimized. Now, I guess how long you stay on it is the question. I think personally that we do well on keto, and then you got to change it up a bit. You can't always keep it that way. But you mentioned a plant forward keto. Does that mean that you're allowing meats,
Yeah.
but you're trying to get a lot of plants in as well?
3/4 of the plate, more or less, is plants.
Okay.
And then 1/4 of the plate is protein of choice. And that, has to be low carb protein, which for practical purposes means, meats, fish, or fowl.
And you like the vegetables for what? The phytonutrients and the
Phytonutrients, sure.
right. So the phytonutrients are the colors within the fruits and vegetables that actually, they're not there just to look pretty. They actually have healing properties that can help heal the body. So you put somebody on a lower carbohydrate, because we're saying, sucker, you're robbing my life. We are not going to feed you sugar. And we're talking to the limes that are floating around, right? We're not talking to the patient. And then what else do you do?
So I'm also going to support Detox with probably some supplements of some kind or another, something that's going to support phase 1 and phase 2 and phase 3 Detox. Going to have them.
Things like sulforaphane, maybe, that things like DIM, methylation. So you would check a homocysteine, I take it.
Yep, that's part of the organic acid profile.
Okay,
Yep.
and if homocysteine is high, we would give them like methyl factors and other things. Interesting. I think I'm the medical director for Human, the makers of Superbeat and Neo40, and they're all about boosting nitric oxide. And I actually just gave a talk to a bunch of practitioners, and what we were looking at happens is that when you have toxicity, and that it causes oxidative stress, and that causes enos, the enzyme that's supposed to make nitric oxide, makes superoxide. And because of that, that superoxide is toxic, your nitric oxide goes down, and you can have symptoms like fatigue and poor circulation and erectile dysfunction and decreased female sexual function. And there's that backdoor approach where you can give people nitrates and nitrite, and we'll actually give them, I have a patient that had Lyme, that his Lyme test that was at Igenics was positive for years. And just by going on a fermented beet powder, it went away. I mean, he worked on exercising and whatnot. His symptoms went away, and it went away. And I've had various patients with chronic fatigue and fibro and Lyme and mold, and I'm seeing them get better with this. Are you working on nitric oxide as well?
Yep. Okay. So that's all part of this post-acute sequelae thing, right? So, all of these mechanistic things that can make us sick for reasons other than or downstream from infection, right? So, nitric oxide wasn't given Molecule of the Year award for nothing. This is important stuff. This is a major communication, intracellular and intracellular communicator. And without good communication, nothing's going to be coordinated. Nothing's going to work right.
Are you giving patients antibiotics?
Almost never. I give them antimicrobial herbs, but occasionally, if somebody comes in and they're fairly acute, I'm going to give them a full round of doxy and the antimicrobial herbs for a variety of reasons.
Well, like I'm sure you're aware, people will go to these Lyme specialists, and they're on antibiotics long term. I'm talking about years and years and years.
I know. Pickline and IV Rocephin for years and years and years. And I used to be one of those. I used to do that.
Okay.
But so here's my story. I used to give antibiotics and they wouldn't get better. So I gave them, somebody said, oh, you got to give double dose antibiotics. So I gave them double dose antibiotics and they weren't better. So I gave them IV antibiotics and they weren't better. And I gave them double dose IV antibiotics and lo and behold, they got better. Well, and then so the next patient, I gave them double dose IV antibiotics right out the chute and they didn't get better. Well, it wasn't the double dose IV antibiotics. It was the chronicity of therapy. And it turns out that you can get that chronicity of therapy with antimicrobial herbals without disrupting the microbiome to such a great, and or mitochondria to such a great extent. Because remember that many of these antibiotics have profound effects on our mitochondria.
Which will make us tired and increase lactic acid and Those are those little cells within our cells that help make energy, that help make
It's the
ATP.
powerhouses within the cells.
The powers. And so as a functional medicine practitioner, we do twitch a little bit with antibiotics. We know that they're necessary in many cases, but we do know that it can throw off the gut, and the gut is the gut gateway to disease. Okay, so you make the body, can you just list what are your favorite antimicrobial herbs that you will use in people?
Specifically for Lyme, there was a study at New Haven University. It's in vitro, but it showed that stevia, the sweetener stevia, was better than doxycycline for the treatment of Lyme.
And now I know you're a fancy guy. I've always said stevia. Is stevia the fancy way of saying it?
Remember at the top of the show when I said I have dyslexia and I can't spell my own name?
Oh, I just thought it was a fancy thing. I did like tomato.
I think so. I think stevia, I don't know what it is, whatever.
Okay. I would have just went with it. I was giving you that, like, I was making you double fancy.
Yeah, no, I'm far.
So stevia, so that's interesting. Stevia or stevia, which is the sweetener.
Yeah, sweeter, some people call it. Yeah.
How do you tell them to take?
So there's a company called Nutrimetics, and if you decipher the code in the paper, it looks like Nutrimetics was the best. Interestingly enough, there's a product called Stevia Side, which is specifically an antimicrobial, and it was the least effective at Lyme disease. But this Nutrimetics Stevia, I have them take 15 drops twice a day.
Okay. And then what else?
Cryptolepsis. Cryptolepsis was studied at Johns Hopkins and was found to be better than doxy and ceftriaxone.
And where do you get that from?
Well, where do I buy it from?
Mm-hmm.
I get it from Orthomolecular.
Okay.
Also, not Boston Scientific, Quicksilver Scientific has a liposomal form for people who have neurocognitive stuff.
Okay.
And then in that same study at Johns Hopkins, it was cryptolepsis, doxy, cephalosporins, and then 4 more herbs. And so there's another product I can't remember the names of the herbs right now. I can look it up, but and I put all those into a bottle, or actually Orthomolecular put it into a bottle too, and they call it, I think, phytobiotic or something like that. And so I give that, and then Biocidin LSF, which is Biocidin is a mixed herbal thing, and the LSF form is a liposomal form. I use that, and so stevia is anti-biofilm. It's also antimicrobial. The Biocidin is antimicrobial and anti-biofilm. So we're kind of treating the issue with Lyme is it's really good at displaying what's known as stealth pathology, this antigen switching and the biofilm formation and losing their cell wall and becoming cyst forms and all that stuff. And so we're trying to attack it from enough or different directions so that it can't get away. And that's the reason for using those 4 specific antimicrobials.
Dr. Sult, that was a fantastic overview of Lyme or Lyme's disease, however we're going to call it. Now it is time to spill those functional medicine organic beans. We are going to go over the things that you can't get from AI or Googling. This is your clinical experience share.
To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive, look at personal experiences and real-world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show.
So part 6, making an impact.
Okay.
So if you look at the functional medicine practitioner as a fruit-bearing tree, that fruit has seeds, and those seeds can be planted, and those plants can grow more trees, which can bear more fruits. So from a functional medicine practitioner point of view, we are all about making a difference, about legacy. So before we wrap up and before we get into legacy, what exciting projects are you working on right now, Dr. Sult?
So, well, I'm working on several fronts. I'm working on organizing a ski trip with my son,
Okay.
which is going to be awesome. We're organizing another sort of family. So my son and I are pretty aggressive skiers, so we want to go off and actually ski. But then we're organizing another trip with a family, bigger family with younger kids and whatever to create those memories. So those are passion projects, getting the family together. And so I like to say I want to do at least 2 vacations a year. One for myself, so I can go out and do the things that I want to do. And a second one for the family. And that's a minimum, right? Minimum of 2. So that we can build those memories and that cohesiveness and all that stuff. So those are my passion projects in my personal life. And then, just living every day with, we live in a house of 4 generations, 8 people, and 5 dogs. So that keeps life pretty busy, and that's a passion project just to try to figure out how to negotiate all of that chaos all the time. Professionally, I am working on franchising the part of my business, which is precision weight management, count toxins, not calories. So, and I use the term toxin very broadly because stress is a toxin. Glycotoxicity, right? Glucose is a toxin, but worse than that, fructose is a toxin. I just wrote a blog the other day about what can bears and berries teach us about the obesity and ADHD epidemic. And, one of the things that bears do in the fall is they eat a whole bunch of berries. Well, berries are high in fructose, and that actually does not stimulate satiety. And so they're able to just eat and eat and eat and eat and eat. Well, guess what happens when you're eating high fructose corn syrup drinks all day long, right? And then many of the environmental toxins that we're all exposed to all day, every day are obesogens. And there's evidence to suggest that a major difference between people who are obese and not obese, when you account for, all the usual suspects of calories and blah, 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 is those people who are obese don't detoxify as efficiently as the people who are not obese. So it becomes a matter of, sort of the biochemical individuality of the individual, whether or not they are detoxifying well, they have a higher risk of diabetes, they have a higher risk of obesity, they have a higher risk of metabolic syndrome, and, all of it that follows from that, heart disease and hypertension and strokes and blah, blah, blah. So, so that's a big passion project right now. And, we've been doing the heart rate variability analysis. Then I talked about looking at the stress component. We've been doing BIA composition and 3D body modeling to get more precise measurements. And we use VO2 max to really assess that transition between where you're burning fat and where you're burning carbs primarily. And since we're trying to detoxify, we want people to burn fat mostly. So most people are over exercising to burn fat. So we're bringing the intensity of their exercise down for most days, and then just 2 days a week, increasing to a sort of a high intensity interval kind of deal. And then supporting detoxification along the way, all forms, from stress management all the way through to industrial pollutants. So that's a big passion project. We're not quite launched yet. So if you want a franchise, get a hold of me, but it'll be a little while because you still have the attorneys working on all that stuff.
Nice. Now, back to legacy and giving back. I just want to tell our viewers that if you are a functional medicine practitioner, And hopefully you're enjoying this content, and hopefully you will share this with, however you're listening to this or watching this, you will share this with your non-conventional or your non-functional medicine colleagues, because really what functional medicine is really about good science. We're tired of people hijacking the term functional medicine. It's any reasonable practitioner would, I believe, once they understand what functional medicine is, they would be a functional medicine practitioner. The other thing is if you have family members, maybe you're a functional medicine champion listening to this, someone that's not a practitioner, think of who you can share this with. And if you have family members that are wondering career-wise what to go into, we need functional medicine physicians and nurse practitioners and NDs and chiropractors and health coaches and so acupuncturists, so mental health therapists with that functional medicine approach. So share this with them. Share this with them. Maybe they'll get into a career where they're looking at the whole system, the body. Dr. Sult, what are some impactful ways that practitioners can contribute to their communities?
Well, so there's a zillion and two, right? Volunteer. In our community, there's something called Tuesday Table where the community comes together. It's shared between a number of churches, and it kind of migrates around the community, but volunteer, serve some meals to people. Be active with, in my case, our son is very interested in theater, so we want to support the theater in the community. Volunteer, just give talks. Talk about your favorite topic. That's how I actually got known in my community. Was I used to go to the local health food store and just give a talk about, you name the thing, women's health or chronic fatigue or arthritis or just wellness in general, whatever it was. And people are screaming for this. They want you to help them educate people. And it's very good for you as a practitioner. It's very good for the store if you're going to the health food store to talk about stuff. And then in a broader sense, what are you passionate about? I'm passionate about raising people out of poverty. So I contributed to an organization called Kiva. And Kiva is a micro loan. They give like $25 loans basically to people. So I've set my system up so that I loan to groups of women. And the reason for that is they tend to be more the spiritual center of the community, and they're usually trying to do things that are more communal, whereas I'm getting in trouble for saying this, but men often are more centered on their own needs and wants. So I loan to these groups of women through Kiva, and they do things like build a store, or they have a repair shop, sewing shop or something like that. And it just helps pull them out of poverty, but helps their community come out of poverty as well. There's a group called Heifer International where I donate to them, and they provide animals of various kinds. It might be a flock of rabbits, it might be a flock of sheep, it might be a couple of cows, it might be a little flock of chickens, whatever it is. And again, it's a sustainable thing. Instead of giving them a piece of meat to eat, we're giving them a cow to milk. And maybe we're giving them a bull and a cow, and now they're going to have more than one, and they won't need that many bulls, so they'll be able to eat those, and they'll be able to milk the cows. And so it's just ways of, the typical, I used to do a lot of mission trips, and it was a bunch of white guys showing up and doing projects. Well, that's to me dumb. I think empowering indigenous people to be able to pull themselves out of poverty makes more sense to me. So that's what. Yeah. Well, I'm an indigenous white guy to Minnesota right now. Yeah.
Okay, good.
Yeah. Although the indigenous people of Minnesota would probably bristle at what I just said, so I apologize.
So what about a larger scale when it comes to better or the cause of functional medicine, like bettering the cause of functional medicine. Like I know I like in donating to environmental work group, and I feel like they're doing the job that
Yeah.
they're actually doing a great job for all of us when it comes to awareness of toxins and chemicals. I feel very grateful for the Institute for Functional Medicine, and they are a non-for-profit, so I'll donate to them as well. But what about you? What organizations do you feel like really will better the functional medicine cause?
Well, you just named the two most important ones, in my opinion. There's a lot of places out there doing work, but most of them are, um, very good educational organizations, but I don't think they're trying to further the culture of functional medicine. And by that, I mean working with institutions to try to bring, functional medicine curriculums into medical schools and residencies. I think the Institute for Functional Medicine is really the major group trying to do that. So, donating to the ifm.org, I think is really important. The Environmental Working Group is doing incredible work at looking at, all of the ways. I used to talk about clean air, clean water, clean food. Well, that's only the tip of the iceberg. We got to have clean cleaning products and clean personal care products. And, there's so much more to it and so many more ways that we're getting exposed. So the Environmental Working Group, ewg.org, is really important. Yeah, those are the two big ones. I don't know that I have a lot of other places specific for the universe of functional medicine. I don't know that I donate to a lot more places than that.
Thank you. No, I think that's a wonderful start, right? So, Dr. Sult, when it comes to giving back, the most valuable thing that we have is our time, and you
Yes.
have been extremely generous with your time. So for that, I thank you, and all of the people that hear this, I'm sure, are thanking you or will be thanking you. How do we stay connected with you if somebody wants to stay connected?
Well, so my website is justbewell.info.
Okay.
And our Facebook is Just Be Well FM. And that sounds like a radio station, but that was FM's meant to mean functional medicine. Just Be Well. If you look on Facebook to Just Be Well and you see somebody that looks a little bit like me, it's probably my page. And those are probably the two best ways. We're on the other things, but do that stuff. I have people who do the social media stuff, so I don't know about Pinterest and all that stuff. But
Awesome. Well, if you have anything that your people know you're doing, let us know, and we'll put it in the show notes. Dr. Sult, once again, thank you very much for coming on. And thank you, like I said in the beginning, you are one of my mentors from the beginning that changed my life with functional medicine. So I thank you again, and can't wait to see you at the next conference.
Yousef, I want to tell you something. Maybe I should call you Dr. Elyaman because you keep calling me Dr. Sult, but this feeling is mutual. You have become my mentor as well. So we've come full circle. It's a beautiful thing when that happens.
That really means more than you could know. Thank you.
Yeah. All righty. Thank you.
Hey everyone, I'm Dr. Yousef Elyaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please, please, please subscribe. Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.